slowly. Thank you for inviting me. I was asked to speak about the characteristic features of respiratory devices in Duchenne muscular dystrophy. So just to remember you, we had a first master class in November 2029, and we created the Ukrainian Home Mechanical Ventilation Consortium. And also we had our first publication. That was all the work of the Duchenne Ukraine Association. Thank you very much for doing all this job. And you see here under the title of the publication, Mechanical Ventilation in Duchenne Muscular Dystrophy, pilot project in Ukraine with the 11 physicians from Ukraine and myself. That was published last year in Pediatrics International. This is the official journal of the Japan Pediatric Society. In my opinion, the future of this consortium is, in addition to DMD, addition to Duchenne muscular dystrophy, the project should include all neuromuscular disorders requiring home mechanical ventilation, mainly in addition to Duchenne, spinal muscular atrophy, SMA, amyotrophic lateral sclerosis, ALS, myotonic dystrophy, DM1, and all other congenital myopathies. Why do I believe that? It is just because when Ukrainian physician and the consortium will ask to the government in Ukraine to reimburse the treatment, they won't do that only for one disorder, not only for Duchenne. They will agree to do that for all neuromuscular disorders. So the future is to have a common fight with all neuromuscular associations within one goal. This is my opinion. So spontaneous breathing in Duchenne dystrophy is what we call shallow breathing. This is a high rate, quick, but also with little volumes. So breathing is not very effective at night during sleep. And this is leading to nocturnal hypoventilation with a high CO2 and a low oxygen saturation. How can we measure that? When we look at what happened during the daytime when awake, oxygen saturation above is normal and PCO2 is also normal. But when we look at what happened during sleep, we see oxygen desaturation under 90% and also CO2 levels under 47. These are the conditions, the indications, criteria to start with nocturnal assisted ventilation. So what will we do with assisted ventilation? We will, just like with a pump, we will blow the lungs to make that the rate will be lower and also that they will be insufflated with sufficient volume of air. This happens with a ventilator, and the ventilator will make that there will be sufficient air in the lungs. This is assisted ventilation. So I was asked to speak about the characteristic features of respiratory devices in Duchenne muscular dystrophy. The strategy is the choice of 4 different technical choices: the mode of ventilation, the device, the interface, and the tubing, the circuit. But you will see with pictures. The mode first. We have 3 possible strategies around the world, everywhere. First strategy is volume ventilators. This is what we used in the master class in 21, in November 2 years ago. When we push volume of air in the lungs, we have no idea regarding the pressure. Second possibility, we push pressure, but then we don't know which volume we will give into the lungs. And this is what we are using now in the master class 23. In the future, we should use hybrid modes with pressure and target volume, where both pressure and volume are known. Here it is an old study 12 years ago from Paris, and you see that in Duchenne dystrophy for NIV, the pressure mode and the hybrid mode are very interesting. For instance, just to give examples, SMA with tracheostomy and severe respiratory insufficiency, the volume ventilator is welcome. But in general, you see that in total, volume, pressure, and hybrid are balanced. So it means that you can use every system. Just use the system you have. Okay, I go further. Second is the device. 3 possibilities. The CPAP. The CPAP is not a ventilator, so it should never be used in Duchenne. The second one is the BiPAP. The BiPAP is the one we are using now in the new patients this year with Dr. Trofimov. And the last one, it is what we used 2 years ago, the ventilator with batteries. So I told you CPAP is not for us, but BiPAP is what we will use now. BiPAP is very interesting. It makes changes between IPAP, inspiratory pressure, and EPAP, expiratory pressure. There are no batteries and no target volume. And this is the volume ventilator we used 2 years ago. But in the reality, what is the best choice in Duchenne muscular dystrophy? Finally, all devices can be good, and all technologies, all strategies can be interesting. The choice finally is made according to the availability of devices on the field. The future will be hybrid devices. This is the most growing mode of devices we use across the world. And probably with the evolution of Duchenne dystrophy, we should favor a device including internal batteries if possible. This is the one we are using now, the ResMed VPAP ST. And Dr. Trofimov will explain this device further. The advantages of this device is that it is intuitive. It is little and light, simple to set. It uses single tubing with leaks. There is an effective trigger. There are few or no alarms. And interestingly, this kind of ventilator, the BiPAP, gives the largest choice of masks. So when you use the VPAP ST, like you are using now, this is the one system giving the largest possibilities of the choice for masks. The disadvantage is no batteries and sometimes limited possibilities for possibilities for alarming. The interface, there are many, many, many different interfaces. And finally, the tubing, you have two different tubing. The one we are using now is the passive tubing with a pressure system, the BiPAP system. This is a system with no exhalation valve, like you see under, but upper you see a system, the VPAP ST, with no exhalation valve and with the leaks directly on the masks. A big advantage of the passive tubing is that this is a good system for triggering, make that the patient can ask for air. This slide is important just to show that without ventilation, the mean age of death can be at around 25 years of age. But thanks to ventilation at night, now recent studies show a mean survival of 35, even sometimes above the 35 years of age. This is a recent publication of our group showing that the prevalence of home mechanical ventilation in general in all neuromuscular disorders based on 22 countries is almost 3 patients with neuromuscular disorder using a ventilator at home by 100,000 inhabitants. The steps for the future, you see in 2021, we had 8 patients and we work regionally in Kropivnitsky. Now we are between 21 and 24, and the idea is to extend the number of patients and to integrate additional regions. I have finished. I see you make big signs. Thank you for your attention. This is our group, and so I'm happy to make this presentation, and sorry for the technical problems.
Thank you very much, Michael. And my name is Natalia, and I am the head of the Center for Orphan Disease. And today we speak in our hospital. And this is very big and very comfortably interesting project for in our experience for 5 days with a lot of patients with Duchenne disease. And thank you for you because you started this project in Ukraine some time ago, and thank you very much for this.